Hello everyone, my name is Sukit Pattarajierapan. I'm a colorectal surgeon at the Faculty of Medicine, Chulalongkorn University and King Chulalongkorn Memorial Hospital in Bangkok, Thailand. On behalf of our research team, I would like to sincerely thank gastrointestinal endoscopy for this opportunity to share the findings of our study titled Risk Factors of Breathing Oscillation After Argon Plasma Coagulation in Patients with Radiation-Associated Vascular Ectasias. Why did we do this study? Radiation-Associated Vascular Ectasias, or RAV, is a new term used to describe the breathing predominant form of chronic radiation proctitis. RAV is a common long-term complication in patients who receive pelvic radiation therapy. Argon plasma coagulation, or APC, is widely accepted as an effective endoscopic treatment for REF. However, complications like proctalgia, ulceration, rectal stricture, and even fistula can occur. Among these, non-healing ulceration is especially concerning. It occurs in up to 56% of patients and can lead to further bleeding or pain. There were many reports of severe bleeding from ulceration after APC, some requiring blood transfusions and even invasive procedures like diverting colostomies. So we asked, can we identify patients at higher risk of developing bleeding ulceration after APC? And more specifically, we wanted to understand whether radiation dose to rectum can predict this complication. What did we find? We performed a retrospective analysis using prospectively collected data from patients treated at our hospital between 2017 and 2021, all had pelvic radiation and received APC for REF. Importantly, rectal dose volume data was extracted from the radiation planning system and converted into equivalent doses into gauge fractions or EQD2, with D0.5 cc, D1 cc, D2 cc, D5 cc, and D10 cc representing the minimum dose received by the highest irradiated volumes of rectal tissue. Of the 77 patients in our study, 6 or 7.8% developed breathing oscillation after APC. Compared with patients without breathing oscillation, those with breathing oscillation had significantly higher vena rectoscopy scores, higher median rectal EQD2 D10cc 75.2 versus 61.7 gauge, lower therapeutic success 50% versus 99%, and lower hemoglobin level improvement 50% versus 89%. Radiation appeared to impair healing after APC in a dose-dependent manner. The optimal cutoff point of rectal EQD2 D10cc for predicting breathing oscillation was 70 gauge. Multivariate analysis showed that rectal EQD2 D10cc 70 gauge or more was associated with breathing oscillation after APC. So, in essence, rectal dose volume metrics, especially EQD2 D10cc, may help guide treatment decisions. Clinical implications. This study underscores the importance of multidisciplinary collaboration between endoscopists and radiation oncologists. Patients with EQD2 D10cc less than 70 gauge, particularly those treated with external beam radiation alone, appear to be safer candidates for APC. In contrast, for patients with EQD2 D10cc 70 gauge or more, especially those treated with brachytherapy, non-abrasive treatment like hyperbaric oxygen therapy or rectal irrigation may be safer alternatives to reduce the risk of post-APC breathing oscillation. What's next? While our study offers useful insights, there are limitations. The dose distribution in external beam radiation is relatively uniform, but brachytherapy creates focal hotspots with steep dose gradients. In such cases, EQD2 D10cc value may have been underestimated in patients who underwent brachytherapy. So we believe larger collaborative studies are warranted to investigate the clinical impact of different dose volume parameters across different radiation techniques in patients with LEF. In conclusion, rectal EQD2D10cc 70 or more is a significant risk factor for breathing oscillation after APC for REF. A multidisciplinary team involving radiation oncologists, To determine the rectal dose volume parameters prior to APC is recommended to guide clinical decision-making. By identifying high-risk patients, we can tailor our treatment, either proceeding cautiously with APC or considering safer non-abrasive treatment when appropriate. Thank you again to gastrointestinal endoscopy for the opportunity to share our work, and thank you all for watching.